This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Breast Cancer Research and Treatment, published in 2026. It's titled, A Phase 2 Study of Atezolizumab in Combination with Stereotactic Radiation for Patients with Triple-Negative Breast Cancer and Brain Metastases.
This is a critical topic for our listeners, Alara. Triple-negative breast cancer, or TNBC, is particularly aggressive. It's defined by the absence of estrogen receptor, progesterone receptor, and HER2 expression. In the neurosurgical world, we see these patients far too often because TNBC has a high affinity for the central nervous system.
Exactly, Dr. Aris. The paper notes that approximately 25% to 46% of patients with metastatic TNBC will develop CNS metastases. Whether it's in the brain parenchyma or along the leptomeninges, the prognosis has historically been quite poor. Even with our best CNS-directed local therapies, like surgery and radiation, median overall survival typically ranges from only 3 to 7 months from the date of brain metastases diagnosis.
And that's the challenge. Systemic therapy for metastatic TNBC generally yields an overall survival of 13 to 23 months, but once it hits the brain, those numbers drop significantly. This study by Giordano and colleagues explores a synergistic approach, combining stereotactic radiosurgery, or SRS, with an immune checkpoint inhibitor, in this case, atezolizumab.
Right. The rationale here is really interesting for our residents and students to understand. We aren't just looking for local control from the radiation, we're looking for a synergistic effect. Preclinical models suggest that radiation therapy can actually enhance the efficacy of immune checkpoint inhibitors.
It acts as a sort of in situ vaccine, doesn't it?
Precisely. In mouse models, RT and ICIs together upregulate tumor-associated antigen MHC complexes and enhance antigen cross-presentation. It also upregulates PD-L1 expression and promotes the infiltration of antigen-specific T cells while reducing myeloid-derived suppressor cells. We've seen retrospective data in melanoma and non-small cell lung cancer suggesting that concurrent SRS and ICIs are well-tolerated and potentially more effective than sequential treatment. This study was the first to look at this prospectively in TNBC.
So walk us through the study design. This was a Phase 2 trial, correct?
Yes, it was an open-label, single-arm, Phase 2 study conducted primarily at the Dana-Farber Cancer Institute. They were looking for patients with metastatic TNBC and brain metastases. The primary endpoint was progression-free survival, but they used a specific model, the Response Assessment in Neuro-Oncology Brain Metastases, or RANO-BM, bicompartmental model.
That's an important distinction for our practicing neurosurgeons. Using the RANO-BM bicompartmental model allows us to evaluate the response in both the CNS and the extracranial compartments simultaneously, which is vital when you're using a systemic agent like atezolizumab. What about the safety protocols?
They built in a safety run-in analysis for dose-limiting toxicity, or DLT. They planned to evaluate the first 6 patients who completed the assessment period before moving forward. They were looking at secondary endpoints like extracranial objective response rate using RECIST 1.1, overall survival, and general safety and tolerability.
Now, the results section of this paper has some caveats.
It does. The study actually closed early due to slow accrual. Between May 2018 and October 2019, they only enrolled 6 patients into that safety run-in phase. However, even with a small cohort, the data provides some very honest insights into the current state of treatment for these patients.
Let's get into the nitty-gritty of those 6 patients. What did the treatment actually look like?
All 6 patients received SRS as planned. Regarding the atezolizumab, the median number of cycles was quite low, just 2 cycles, though the range went from 2 up to 16.
And the primary concern with combining high-dose radiation like SRS with immunotherapy is often toxicity, specifically things like radiation necrosis or severe immune-related adverse events. What did the safety data show?
That's actually a positive takeaway. There were no dose-limiting toxicities observed. Treatment-related adverse events, or TRAEs, occurred in 4 out of the 6 participants. That's about 66.7%. However, all of these events were grade 2. They didn't see the high-grade toxicities that might have prohibited this combination. So the authors concluded that concurrent SRS with atezolizumab was indeed feasible.
Feasible, yes, but what about the efficacy? If the primary endpoint was bicompartmental PFS, how did they fare?
This is where the news is tougher. The median bicompartmental PFS was only 1.3 months. The 95% confidence interval started at 0.95 months, and the upper bound wasn't even reached because of the small sample size.
1.3 months is a very short window for progression-free survival. It suggests that despite the local control of the SRS, the systemic or intracranial disease elsewhere was progressing rapidly. What about the overall survival?
The median OS was 9.7 months. Now, if we compare that to the historical 3 to 7 months you mentioned earlier, Dr. Aris, 9.7 months sounds slightly better on the surface, but given the small N of 6 patients, we have to be very careful with that interpretation.
Did any patients show a significant response?
One participant, about 16.7% of the group, showed stable disease for 24 weeks or longer based on RECIST 1.1 criteria, but for the most part, the outcomes were poor.
It's a sobering reminder. Even though we have these advanced tools, SRS and checkpoint inhibitors, the biology of triple-negative breast cancer remains a formidable opponent. The authors mentioned the abscopal effect in their introduction, the idea that local radiation could trigger a systemic immune response. Did they see evidence of that?
Not in this cohort. With a median PFS of 1.3 months, it seems the disease was moving faster than the immune system could be primed. The study really underscores that while the combination is safe, we haven't yet cracked the code on synergy for this specific subtype of breast cancer.
It's also worth discussing the slow accrual that led to the early closure. For our residents who are interested in clinical trials, this is a common hurdle. Why do you think they struggle to recruit?
Well, the paper doesn't dive deep into the specific reasons for the slow accrual. We know that TNBC patients with brain metastases are often very ill and may have trouble meeting strict trial eligibility criteria. Furthermore, by the time many patients reach this stage, they may have already been through multiple lines of therapy, making them less eligible for certain experimental protocols.
So what is the bottom line for the neurosurgeon in the clinic today? If a resident asks you tomorrow morning during rounds, should we be pushing for Atezolizumab alongside our SRS for TNBC brain mets? What does this paper tell us?
The takeaway is that it's feasible and safe. You likely won't see an increase in dose-limiting toxicities. However, we cannot yet say it significantly changes the trajectory of the disease. The authors conclude that the development of effective therapies for these patients remains a significant unmet medical need.
I agree. It's a call to action. We need better systemic agents that can cross the blood-brain barrier or more potent ways to modulate the immune environment of the brain. The synergy we see in melanoma doesn't always translate perfectly to TNBC.
Exactly. And for the students listening, this study is a great example of why we do phase 2 safety run-ins. Even a study that closes early and shows poor outcomes is valuable because it tells us where the current ceiling is and where we need to focus our next research efforts.
Well said, Alara. To summarize, concurrent SRS and Atezolizumab, feasible, no DLTs, but median PFS was only 1.3 months and OS was 9.7 months in a very small sample.
That's it for today's deep dive. We hope this helps you in your next multidisciplinary tumor board meeting.
Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time.